So Richter's transformation of CLL represents an unmet medical need where it occurs in about 5% of patients with CLL. And if you look with chemotherapy, the average survival is less than 1 year. So we and others have started to look at using checkpoint inhibitors for patients with CLL. One of the first studies in this regard was done from Mayo Clinic by Dr. Wei Ding. Subsequently, we had a clinical trial combining Nivolumab with Ibrutinib, which was recently published, where we treated about 24 patients who had relapsed refractory, most of them had relapsed refractory Richters, DLBCL Richters. And we gave them Nivolumab, which is a PD-1 antibody, and Ibrutinib, which is a BTK inhibitor together. And we saw that 10 of the 24 patients had a clinical response. Some of these patients were then able to go to stem cell transplant as well. So based on this study, this regimen of Nivolumab plus Ibrutinib is now actually on the NCCN guidelines. So potentially, clinicians can prescribe it to their patients and they can provide the NCCN guidelines as a reference. And as I said, the paper is already published. So certainly there is a role for some of the patients who can achieve some durable remission with this strategy. One thing we did note in the study is that patients who had prior Ibrutinib were less likely to respond to this regimen. Patients who had no prior Ibrutinib were more likely to respond to the regimen of Nivolumab plus Ibrutinib. At the same time, there are other BTK inhibitors which are being pursued now, including non-covalent BTK inhibitor Pirtobrutinib, which already there is data out there in Richter's transformation, and we others are now looking more prospectively for Pirtobrutinib in clinical trials for patients with Richter's transformation.